Hi, my name's Claire Harrison. I'm a doctor working in central London at Guy's and St Thomas's Hospital, and here at the EHA 2026 in sunny Stockholm, I'm really pleased to bring some summary of updates of this meeting to your listeners who have got MPNs. So if you've got ET, PV or myelofibrosis, here are some updates for you from this meeting. First of all, of course, this is a meeting where the MPN community come together. We're an incredibly collaborative community. We meet as scientists, clinicians. We also meet with patient organizations such as HealthTree, but also industry, and try to form good plans and ideas. In this meeting, I think we've really moved as a field. And in fact, I gave a talk titled this From Damashek through to Disease Modification. So for the listeners who don't know, Damashek was the editor of our journal Blood, who first used the term myeloproliferative disorders. So he invented the term for the disease. So from Damashek to disease modification, a journey of MPNs. So where have we journeyed to here in the EHA meeting? And also, I'm going to share with you some of the updates from ASCO. So I would say there are 4 main updates here specifically for MPNs. Of course, many other items discussed, but just want to share with you first results from the SENTRY study, which is a study with a drug known as Selinexor, which is used a lot for patients with myeloma. That means we know a lot about the drug. Around 40,000 people have taken this drug worldwide for other indications, but it might work for MPN because it targets the AJAX signaling, it targets cell replication, that means cell turnover, and it promotes death of malignant cells. And also it targets a specific cytokine pathway called NF-kappa B. There are other agents we use that target that pathway, so we know it's good. In the SENTRY study, we took patients with newly diagnosed myelofibrosis needing a treatment, and everybody got Ruxolitinib. You're familiar with that. It's a JAK inhibitor or Jakafi that is routinely used in practice. And then patients were randomized either to get Selinexor at a lower dose than is used in myeloma or placebo. So we didn't know, and the patient didn't know what they got. And we just got the readout of the results after 6 months. So it's a top line, headline if you like. We saw double the number of spleen responses, which is important because spleen response is linked to survival benefit. More on that in a moment. But I have to say that we didn't see an improvement in symptoms, which is what was required as an endpoint in the study. So that's a little bit of negativity, but the magnitude of symptom improvement that was enjoyed by the patients on Ruxolitinib was the same as was enjoyed by the patients on Selinexor combination. Other factor we saw was there were no new side effects of Selinexor. So we know about fatigue and we know about nausea, and patients just take it once a week with anti-sickness medication, and that was manageable. But the surprise and really strong message for me was we saw a survival benefit just within 6 months. And not compared to just placebo. Everyone was getting Ruxolitinib. This meant that there was about 50% reduction in risk of death. Please remember, though, really not many patients are going to die within 6 months of starting a treatment for myelofibrosis. So we need to see this data maturing. It links to spleen reduction and it links to reduction in mutations, so also important. Maybe disease modification through those mechanisms. Look out for week 48 data with this combination. And if you're on the study, please stay on if you possibly can. And thank you so much to all the patients who've been on this study. Being in a clinical trial is really important. It helps other patients, but it also, there is good evidence that patients on clinical trials actually have really good outcomes. The second update that I want to share with you in some detail is with regard to calreticulin therapy. Remember that calreticulin mutations is the second commonest mutation we see in MPN, mainly in patients with myelofibrosis or ET. And the mutation generates a totally novel protein, which is only expressed on the outside of the cells that have the mutation. So it's not tagged on normal cells. And we've been developing in collaboration with pharma companies an immune-based therapy. So other blood cancers such as myeloma and lymphoma, we use immune-based therapies. That means antibodies and immune cell therapies like we needed to fight off COVID, for example. We have these therapies that can recognize that abnormal protein and then tag out the malignant cell. And we've seen results in ET where the platelet count comes down nicely, and we've got patients as young as 30 and as old as 83 on this therapy. We see no dose-limiting toxicity, remarkably well tolerated. They just rock up, get a 30-minute infusion, and off they go. So for myelofibrosis, this is a very difficult disease to treat, and what I'm presenting here at this meeting is that we saw really good rates of spleen responses, symptom responses, as I just discussed with Selinexor, but further, we start to see the bone marrow normalizing. We start to see the disappearance of malignant cells, and if a pathologist was looking down the microscope, they wouldn't recognize some of these patients' bone marrows as being a patient with myelofibrosis. So I think this is super exciting. You can expect a lot of new CALR-targeted therapies in the future, but also a study in both the front line and the second line, and also for patients with ET. If you're a PV patient, this can't apply to you because you won't have the CALR mutation, but there are other updates that I want to share with you now that are relevant to you. So also in this meeting, we see a presentation from AJAX Therapeutics. They just got bought by Lilly because their data is so exciting. They have a JAK inhibitor which is more specifically targeted to the mutation. Our current JAK inhibitors don't recognize the mutation, they just recognize the downstream effects of the mutation. So this drug appears to be very well tolerated, spleen and symptom responses, control of the blood count, but also reduction in the amount of mutation, which for JAK2 patients, we know that even a 50% reduction in mutation, if you're a patient with PV, means that you have a survival benefit. So start asking your clinician about your JAK2 mutation burden or VAF or allele burden. In addition, we also have the results of a study with Luspatercept, which is an agent used to manage anemia in MDS and other disorders. And we've been looking at it in combination with a JAK inhibitor. On-target effects of JAK inhibitors include anemia. And we saw strong results from the independent study. Slightly complicated to understand, but nonetheless a strong signal that there was anemia benefit without toxicity for patients. And then lastly, I just want to highlight that I'm super excited to see that one of my colleagues from Oxford University, Adam Mead, fantastic colleague and collaborator, he is a brilliant scientist and he's identified maybe a new target for MPN. It's called G6B. So write that down and watch out for it. It tags all MPN cells, doesn't matter what mutation you have. So super excited to bring you these updates. Take care, everyone, and stay well.